real pleasure to be here. I'm just going to share my slides, and hopefully you can all see that.
Yeah, looks great.
Okay, great. Okay. All right, so I'm really pleased to be here and talk with everyone about principles of psychotherapy with young people. And I have just a few disclosures. I get some research funding from grant agencies, the Michael Smith Foundation, Social Sciences and Humanities Council, and I have a very small amount of royalties to disclose from a book called Contemporary Psychodynamic Psychotherapy. But I don't expect there to be bias undue bias anyway in the content of today's talk. I'm not going to be speaking about my private practice or service work. So I thought I'd kick things off by posing the question, where are we at? What's the current state of psychotherapy for young people? Probably, I doubt that I'd get much disagreement about this, but limited access is probably where things are at in terms of getting psychotherapeutic help for adolescents and young adults here in BC. Often people report to me that they can make use of some online apps. They find that helpful, but it's not really the same as the psychotherapeutic experience. Other people can get a few sessions at a campus counseling center. That's not uncommon, but those places are often overwhelmed with demand. And in many settings, young people often find themselves receiving some psychoeducation, a few little tidbits from CBT and DBT workbooks. And again, it's all to the good, but perhaps not quite enough. And I think a prominent issue in our province is that when young people age out of the adolescent care system at 18 or 19 years of age, the adult services are often not adequate to meet their mental health needs. What about in terms of evidence-based treatment? Where are we at there? Well, that movement continues to focus on a diagnosis of a clinical disorder and the delivery of a specific treatment for that disorder. Now, unfortunately, that doesn't always fit for young people who are looking for help, and doesn't always fit in the kind of setting that young people find themselves in, where the services are delivered by a counselor, someone who's not in a position to offer a clinical diagnosis. It's not necessarily what the young person is looking for either. Some of the issues with this evidence-based movement is that treatment tends to be guided by a manual that determines the kinds of techniques that the therapist is going to deliver to the client. That has advantages in terms of standardization and targeting specific symptoms. We know, for example, that in some disorders, such as anorexia, it's very important to target symptoms and to be talking actively about managing those symptoms. But a lot of people are looking for more than that, or looking for something different when they're coming for mental health support. The other issue with these evidence-based treatments is that they may not always be delivered in the real world with fidelity to their intended delivery. For example, DBT, the full package of DBT, involves multiple components, and a lot of care systems don't actually live up to that. Instead, the client might find themselves in a skills group, but not having the individual therapy, and certainly not having access to extra session coaching experiences. And so the other main disadvantage of this evidence-based approach to treating young people is that these specific technique-oriented treatments may not actually address what's most salient to the client. It puts us in a position of choosing, which kind of therapy am I going to use for the particular problem that the person is coming in the door with. And how do you know, right? How do you know what to choose? Moreover, when you compare these different approaches in randomized trials, direct comparisons reveal minimal differences, if any. This is a repeated finding over and over again. when two bona fide treatments that are intended to work are compared against each other, they show very little clinically significant difference, which has, given rise to this dodo bird effect, which refers to this all have won, all must have prizes quote from Alice in Wonderland, that these therapies have not, despite a considerable amount of research, we have not been able to show that one therapy is better than another, that there's a sort of gold standard, if you will, of therapies. And so one suggestion is that the effectiveness of psychotherapy may rely more on common factors, something that's shared across these different approaches, or core principles that most therapists are using, and on therapists' ability to respond to the individual client's needs and to tailor the treatment specifically for that person than specific techniques. We don't really have good evidence that the specific intended mechanisms of action of a treatment like CBT, for example, is actually what's driving the bus in terms of outcomes for clients. So if we look more at a principle-based notion of delivering psychotherapy, what are the advantages of this? In a nutshell, personalization. And I can't emphasize this enough, that when we rely on principles rather than delivering specific techniques for particular problems, we're better able to tailor our interventions to the individual's goals, their needs, their sensitivities, the client's strengths, what they're capable of, as opposed to what they may not be capable of in that particular moment. The client's preferences, we have good research to suggest that honoring clients' preferences is associated with positive outcomes in psychotherapy. And the client's style, their way of relating, their personality, if you will. When we do this, when we can employ principles in a personalized way, we're more likely to improve our ability to be responsive to the client, to do what's right, and to do what's therapeutically optimal in this particular moment. So what are some of the principles for working with young adults in psychotherapy? I've outlined three that I think are critical that I'm going to expand upon a little bit in this talk. The first is to take a developmental understanding and to contemplate what kind of identity-related issues might the young person be working on. If you think back to your introduction to psychology courses, Erickson's model, there are aspects of this model that still hold up. The idea that young adults might be working on particular developmental tasks when navigating their identity, still something that's quite relevant today. These sort of conflicts, if you will, around, can I develop a sense of identity, or will I remain kind of diffuse and confused in terms of my sense of who I am? Can I develop a sense of intimacy and a capacity for relatedness with others, as opposed to feeling isolated and alienated and cut off from my peers? There's also a notion of possible selves. Who can I become? Who am I becoming? What kind of future can I look forward to when we think about a developmental lens in working with young adults? Second major principle I would submit is safety, that we want to promote safety in psychotherapy. This connects with the idea of being trauma-informed, understanding what's happened to the client, what's shaped them, and how can we provide a space and an experience, a relationship with the client that will facilitate psychological work through the promotion of safety. And finally, to what extent can we develop corrective experiences for the client, both within the therapy relationship and beyond, outside the session? So getting into that first principle around having a developmental lens, what do we mean by identity in adolescence and early adulthood? Well, we know that young people are working on pretty important personal questions. These have a lot of weight for people's future development. coming up with a sense of who am I, what kinds of values and beliefs define me and are consistent across time and across different contexts. What am I doing in my life, and what kind of relationships do I want to have? What kind of work or career do I see for myself? And indeed, who can I become, and what kind of future do I desire or expect, as opposed to a future that I might have resigned myself, perhaps prematurely, without contemplating a range of possibilities that are in line with core values and beliefs. We know that identity is highly individualized. It's like a psychological fingerprint. No two identities or developmental trajectories are alike, which, if you think about it, really speaks to the need for personalization in psychotherapy. So translating this developmental lens and this focus on identity to the kind of guiding principle in psychotherapy, for me, resonates with having respect for the young person's autonomy, consider the client's individual goals, and actually to do this in a way that's a little bit more sophisticated than just running with whatever the stated goal is for therapy, but to take a step back, think about the bigger picture in terms of developmental and life goals, and develop some inferences collaboratively with the client about what it is that they're working on. We want to try to consider where the client is at currently in terms of their identity development. And this final point, which I'll touch on a little bit later on, to follow the client's plan for therapy. That often means letting the client lead the way, or developing a formulation of what it is that the client's working on and what it is that the client will need for the therapeutic experience to be optimal. Moving on to the second principle around safety, I would also add that this too is highly individualized. If you think about it, when we feel unsafe or endangered, we're directing our attention and our resources to addressing the threat, rather than devoting our attention to becoming self-reflective, to developing insight and understanding, and working on higher level growth-oriented goals. So keeping that in mind, we want to promote safety with our clients, with young adults who are coming for help. And again, we should consider this is very individualized. What might make one person feel safe might feel endangering to someone else. If you take, for example, the therapist occupying a kind of expert role or having authority in the room, if you will, for some clients, that will promote a lot of safety. We know that some people derive benefit from feeling like they're being cared for by an authoritative expert. But for other people who are very sensitive to issues around autonomy and control, that could feel like a power struggle, and it could make them feel less safe, indeed endangered, and therefore unable to really connect and forge a therapeutic relationship. So translating safety into a core principle would be not to assume that there are universal signals of safety. That is, that we need to tailor our stance, if you will, to the client in order to promote safety for that particular individual. The better we know the person and the better we can understand what they're working on, what they're all about, the better able we'll be to figure out what it is that's a cue for safety for the young person. I think when we can establish safety, we can trust that the more safe the client feels, the more likely they'll be able to engage, the greater a sense of rapport they'll develop with the therapist, the more likely they are to disclose something to the therapist and then engage in psychological work. So principle that I follow a lot in my work, which is that if I hear a client disclosing something that's new, that's important, that's insightful, or that's painful, I try to think about what came before that. Whatever I did before that likely helped the person feel safe enough to open up. And so that can be a guide for moving forward, sort of like do more of that, and you're probably going to get greater engagement and deeper disclosures and psychological work. Moving on to the third principle around corrective experience. Once again, these are highly individualized. What I mean by corrective experiences is that these would be experiences that for the client violate their expectations in a good way to provide them with a new kind of learning. There's some emerging consensus. I'll point to the work of Marv Goldfried on this, that corrective experiences are fundamental mechanisms of change across all major psychotherapies. Any therapy worth its salt is probably promoting some new corrective experience that helps the client see themselves a little bit differently, get a different perspective on a problem that they have. In other words, they come into therapy with a particular expectation about themselves, about their relationship, the kind of relationship that they can have with others, about their capabilities or possibilities. And in some way, the therapist promotes something different that allows the client to shake up this expectation and adopt a different perspective. I want to stress here that this isn't a one-time experience and then we're done. Sort of the expectation has totally diminished. Corrective experiences probably need to keep happening in a repeated fashion over the course of the treatment. But getting back to the individualized piece, what's corrective for one client may not be for another. And what's corrective at one point in time may not be for that same person at another point in time. Especially when you think about how young people are working on diverse identity-related goals. They may be working on one particular aspect and need a particular kind of corrective experience at one juncture, and then need something quite different later on. We might think that an intervention is corrective or providing a corrective experience for a client. After all, the model or the therapy manual might say so. But is it really for this individual? I think thinking about corrective experiences in an individualized way really demands that we try to take the perspective of the client. How is the client experiencing this intervention at this particular moment? How is it landing on them? How is the client experiencing their relationship with me and what I'm about to say to them right now? So it really helps us get into that empathic stance where we can determine what is likely to be corrective for that particular individual. Another principle related to this is to consider ways in which corrective experiences may be facilitated within the therapy relationship itself, and for us to monitor the client's responses to our interventions so that we can see, are we on track or not? Did the client just open up more? Did they just seem to engage in a deeper way, did they develop new insight? Or did the client sort of become a bit more withdrawn and closed up and have little to say? Or did the client, did their mood seem to take a turn for the worse just then? That gives us a clue as to whether we're being corrective or not in an individualized way, rather than following the manual that says, this is corrective and that's not. How do we know? How do we know what's likely to be corrective? Can we get an idea about that in advance? I think we can. Control mastery theory provides a framework for understanding the therapeutic process and actually suggests that the client has an implicit plan for therapy that therapists can try to make inferences about and develop a formulation to guide the therapy rather than rely on a priori notions of what a particular treatment model suggests is likely to be helpful for a particular disorder. From this perspective, many therapeutic techniques could potentially be useful. So this really promotes the idea of integration across different therapy models. Maybe cognitive intervention would be useful. maybe behavioral intervention, maybe a psychodynamic interpretation, maybe a somatic experiencing or an emotionally focused intervention could reach the client and promote safety in this particular moment. So according to control mastery theory, there's no one particular technique that is the be-all and end-all in terms of effectiveness in psychotherapy. Keep in mind the research showing that different schools of psychotherapy are roughly equivalent in terms of efficacy. But a technique is likely to be helpful if it takes account of the client's developmental goals, if it facilitates safety for the individual, and if it involves some form of corrective experience, potentially including the therapy relationship. So these three principles that I'm outlining here, I think can be used to evaluate the degree to which our techniques could be particularly useful for a potential client. When we think about inferring what the client's plan for therapy is, there's a model here that we can use. It's called a plan formulation. What is the client's plan for therapy? If the therapist can get on board with what the client's plan is, we're much more likely to be responsive, promote safety, and provide corrective experiences. So we formulate a plan thinking about the client's goals. What are their adaptive developmental goals? Not necessarily just the ones that they tell you about, but we can infer beyond what's stated. When you think about the person's life history, the kinds of traumas that they may have experienced, and you know, the kind of strivings that they have in terms of where they're going, what kind of possible selves they may be striving towards. We think about the obstructions, what's getting in their way of achieving their developmental goals. And in particular, I'll focus on pathogenic beliefs. I think there can be many obstructions to goals. Certainly, many of you work with people who experience social structures, marginalization, oppression, poverty. These are very real external barriers to clients' developmental goals. But for the purpose of our conversation today, I'm going to focus on an internal obstruction that we refer to as a pathogenic belief. So we can formulate those beliefs and get an idea of what it's like to be in the client's head, dealing with pathogenic beliefs that are holding them back. We also think about the kinds of traumas that may have contributed to these obstructions or pathogenic beliefs. So we have a sense there of what the client's walking in with in terms of what they're trying to do, what they're trying to overcome, what they're trying to strive for, what kinds of barriers, beliefs are getting in their way, and the kinds of traumatic experiences that have contributed to and or even reinforce those pathogenic beliefs. Then we can formulate what kinds of insights or experiences might benefit the young person. What do we think could facilitate safety once we have a sense of the person's traumas and pathogenic beliefs? What is it that will facilitate safety in our relationship for this person and help them move to a place where they can engage in meaningful psychological work? And finally, how might the client seek corrective experiences in therapy? And we think that one way in which people do that is by testing their pathogenic beliefs in the relationship with the therapist. So just want to spend a few minutes here talking about what gets in the way of people's developmental goals, because this is a central construct that I think is important across all psychotherapies. People are held back by pathogenic beliefs that arise in the context of traumatic experiences. People are trying to adapt to their experiences of adversity. And through adapting, they often develop pathogenic beliefs that in a way serve to explain for them the awful conditions that they find themselves in. So for example, in conditions of say, emotional neglect during childhood. A child might develop a belief in adaptation to that trauma. I don't deserve to be cared for or protected, or I am unlovable. I cannot rely on other people to be close with me and have a caring relationship. Or someone might develop the belief, if they grow up with a parent who is narcissistic and attention seeking, I must be deferential to have a close relationship with someone, or I must look after another person's emotional needs and help them feel admired and subjugate my own emotional needs in order to have a close relationship. So we can formulate, once we get a sense of the person's history and current situation, we can formulate and infer the kinds of beliefs that may be operative for the client. And these beliefs exert a really constricting influence on people's ability to move forward in their life and pursue the kind of goals that are relevant for them. They may inhibit people's efforts to try to even think about what's possible for them, or if they do have some inkling of what it is that they'd like to pursue, these beliefs may warn the person that if they attempt to pursue them, there's likely to be some kind of danger or failure to ensue. So I want to change course for a few minutes here and talk about how we've been working to validate this kind of principle-based orientation to psychotherapy. We recently engaged young adults in a trial, a randomized control trial for psychotherapy targeting identity distress. So we invited young people to approach us if they self-reported having distress related to any aspect of their identity, difficulties figuring out what they wanted to do, difficulties in their relationship world, in their emotional life. Basically, people who are struggling, having a hard time figuring out who they are and who they want to be, and having a lot of distress related to that. We screened them. They had to meet certain criteria around identity distress to be eligible for the study. And we randomized them to either the treatment or to a wait list. And then after the wait list, they received the treatment after they waited. The therapy was all provided by Zoom. This would happen at the tail end of the pandemic. And we didn't have a manual of predetermined techniques. There was no hierarchy of interventions. Do this if the client says this, or do that if the client presents with this issue. Instead, we aimed for a personalized, principle-based approach that used this plan formulation to guide the therapy. Therapists were all grad students. We deliberately chose therapists who were non-expert. We wanted to show that plan formulation can be used at an entry level. So therapists were grad students in social work, counseling, psychology. We supervised them throughout the therapy to use the plan formulation to come up with their own inferences about what it was that the client was working on and struggling with. And the therapy was basically conversational, with the therapist following the client's lead. And this is what the therapists were tasked with doing, with understanding the client's goals and pathogenic beliefs, adopting attitudes that would facilitate safety and disconfirm pathogenic beliefs, and to recognize and respond appropriately to the client's testing. And in the course of doing so, to promote reflection about identity and possible selves. So we recruited young adults for this. I won't go through all of the demographics here, but we randomly assigned 41 clients to the wait list. 35 of them completed the wait list. We assigned 47 to the therapy, which we called potential selves. And of the 47 who were assigned to that condition, 44 of them completed 12 sessions. So 2 clients dropped out before the first session, so prior to even seeing the therapist. Once the young person once young people came to the therapy and had a session with the therapist, only one client dropped out. So when you take that into account, that's a 94% retention rate, which is pretty dramatic for a young adult psychotherapy. Rates of attrition in psychotherapy usually float somewhere between 20 and 25% dropout. And I think for young adults, it tends to skew a little bit higher. So we're very pleased that this intervention seemed to be very acceptable to young people. They were really keen to work with therapists who were trying to personalize the therapy to the young adults' individual goals and issues. Clients had 12 sessions of therapy by Zoom with the therapist. We asked them what they thought of the therapy afterwards. How helpful or unhelpful was it to you? Rated from 1 to 9. So 40 out of the 44 who completed scored 7 or above, moderately to very helpful. A majority also scored similarly for how much worse or better do you think you're doing now, indicating most felt moderately to very much better. And in terms of to the extent to which their original problems or symptoms improved, 30 out of 44, so 2/3, said quite a bit to very much. So clearly there was still some who left treatment feeling that their issues hadn't fully been resolved. But nevertheless, I think these indicate a pretty solid level of satisfaction among these young adults with this approach. We also measured a bunch of constructs related to identity over time. And we saw significant time by treatment effects with superior results for the treatment condition compared to the control. In terms of identity distress, identity diffusion, borderline personality symptoms, self-esteem, and personal growth initiative, the kind of striving to keep developing and moving forward in life. And on average, these were medium to large effect sizes, and these gains were sustained at 3 months follow-up. These are very basic stats, and we're going to be doing more sophisticated mixed modeling where we can nest clients within therapists, but I expect similar results to come through. So just to sort of derive some major principles from this work, we argue that the underlying the presenting problem of young people are powerful pathogenic beliefs that are often unconscious, that are inhibiting their pursuit of adaptive goals and their sense of possibility for themselves. And that young people come to therapy to work on overcoming these beliefs, and they'll assess whether the therapist can help them in this regard. If a person feels that the therapist can help them overcome their pathogenic beliefs, they are likely to continue in therapy and to do productive work. If they feel that the therapist is unlikely to be able to help them, I think that's when we'd see dropouts, or we'd see people having a negative reaction to the therapy, or at least lack of progress. So we think that clients are coming to therapy with these questions in mind. Does the therapist say or do things that indicate an opportunity to disprove my pathogenic beliefs and help me move closer to my goals? And we can wonder, can the therapist do this through offering insight or interpretation or other therapeutic techniques, or through the therapy relationship itself? We don't see that being, we don't think there needs to be a horse in that race, so to speak, that any kind of technique, as long as it's an appropriate therapeutic technique or an appropriate aspect of the therapy relationship that's within our professional standards and boundaries, it's fair game. If it can help the client disprove their pathogenic beliefs, then it's likely to be a good thing to do. So taking stock of all of that, it's critical to infer and to develop an understanding of the pathogenic beliefs of this particular young person. That would sort of be the main message, main takeaway from today. Another major principle that we would derive from this work is the notion of treatment by attitude. This is a concept from control mastery theory that I think is particularly useful when working with clients who don't seem to be willing or able to assimilate the therapist's explanatory comments, cognitive interventions, or insight promoting interventions. In other words, the client isn't really working at a content level in terms of what the therapist is trying to teach the client or engage the client in at a technique level. The client may primarily be working via treatment by attitude. In other words, the therapist should tailor specific therapeutic attitudes that are likely to help disconfirm the client's pathogenic beliefs. So, for example, someone who has a pathogenic belief that they don't deserve protection would be helped by a therapist with a protective attitude, even if the client shows up in session and refuses to do homework and doesn't seem to absorb anything that the therapist is saying, reports, continuing to engage in risk behaviors and doing self-destructive things. If the therapist has an attitude of care and protection toward the client, because that client suffered traumas and adapted to the trauma by developing a belief that they don't deserve protection, the therapist's protective attitude is likely to help the person stay engaged and eventually make use of therapy. But in contrast, you could have a client who similarly is not working with the therapist's content and conversation, but that person may have a dominant pathogenic belief that she doesn't have the right to choose for herself, that she must defer to an authority figure. That person would not benefit from a therapist with an overt protective attitude. Instead, they might do a lot better with a therapist who evinces a kind of laissez-faire, let the client choose kind of attitude, promoting the client's agency rather than emphasizing protection. Another major principle is the concept of testing, that clients test their pathogenic beliefs in their relationship with the therapist. So test is a trial action by the client. They may come in and do something or say something, maybe even something that's provocative, so that they can see how the therapist will respond. And they want to see, will the therapist's response promote safety for them, or will it be potentially endangering? Will the response confirm or disconfirm a pathogenic belief? So a person might place the therapist in the role of a traumatizing figure. Maybe a person who experienced a lot of abandonment or neglect in their development comes to therapy one day and says to the therapist, I've been thinking, I'd like to reduce how often we see each other. In fact, maybe I don't need to keep coming anymore. Maybe we're kind of done. You've been helpful, but I think we should stop. They might actually be inviting the therapist to be neglectful or abandoning in the way they once experienced. And they're wondering, will the therapist repeat this pattern, or can there be another possibility? What they may unconsciously hope for is for the therapist to challenge them and say, I'm interested to hear more about why you want to stop working together, because you've been making progress, and I think there's more for us to do. Let's talk more about this. That might help disconfirm the belief that they are deserving of abandonment or neglect. Alternatively, a person might position the therapist in the role that the client once occupied, while the client, in an attenuated way, traumatizes, so to speak, the therapist. They do to the therapist what was once done to them in order to learn something new from the encounter. So a client may come and devalue the therapist, criticize the therapist, tell the therapist what a bunch of rubbish it was that he said last week. Now, Someone said that to me, I'd have to take it seriously for a moment and wonder, maybe I really missed things. Maybe I was really off the mark and I want to investigate. But if it becomes a pattern, I might think to myself, maybe this person is doing something in me that was once done to them. And they're wanting to see that I can weather that storm, that I can withstand it and develop some resilience and not develop a pathogenic belief in the way the client had to when they were younger. We look for signs of progress. We adopt a developmental lens when we're thinking about progress and outcomes. So it's not just about symptoms. We're wondering, is the client moving toward their goals? Are they changing their experience of their self, their experience of others? Are they strengthening their identity and sense of possibility? And how are they functioning beyond the session? We can also look for immediate signs of progress within sessions to evaluate if sufficient safety is being facilitated by the therapist. Is the therapist compatible with the client's plan? Does the client seem more relaxed, less defended? Are they revealing new material? Are they developing deeper emotional experience or insight in the session? So we argue that therapy for young adults ought to be personalized and that we think a range of techniques may be helpful, but only if compatible with the individualized plan of the client. So going back to these principles, we can evaluate our interventions and techniques to the extent that they account for personally relevant developmental goals. Do they promote safety, and do they facilitate corrective experiences that help the client disconfirm pathogenic beliefs? And so I think we've got some time for questions, and I just want to acknowledge some colleagues and contributors to this work.